Good afternoon. This is the Health and Adult Social Care Scrutiny Panel meeting. The agenda is as published. We have one apology. Councillor Ishrat Ali is unable to attend. And the other members, I'll start with Councillor Addy.
Councillor Beverley Addy, Combe Valley Ward.
Councillor Jill Lawson, Crossland Moor and Neverton Ward.
Kim Taylor, Voluntary Co-op Tea.
Helen Clare, Voluntary Co-op Tea.
Councillor Munro, Almondbury Ward.
Councillor Habib Zaman, Batley East Ward.
Yes, thank you. We also have in attendance Councillor Smage, and if you'd like to.
Councillor Liz Smage, Chair of Overview and Scrutiny.
And Councillor Ramsey, if you'd like to introduce them.
Councillor Ramsey, Lead Member for Health and Adult Social Care.
Cabinet Member. Cabinet Member. Yeah.
Yes, Lead Member, Cabinet Member.
Right, thank you for that. We any interest to declare? No, thank you. Admission of the public. Usually we would hold public sessions. Just check with officers, any reason not to hold a public session?
All items are being considered in public today, Chair.
Thank you. Are there any deputations or petitions?
None received, Chair.
And any public questions?
None received, Chair.
Right, thank you for that. So we're cracking through the agenda, we're doing very well. I understand Health Watch would like to address us. I'm not sure which one's from Health Watch.
Health Watch were going to join via Teams, but they've not arrived as yet.
Right, well, we'll see if the login might be technical issues.
I did email her all the codes to get in as well, so she did have the appointment and the codes as well.
Yolanda, sorry, it's me. Health Watch is in Teams.
We seem to have just a bit of a technical hitch there. One moment, please.
Just bear with me.
And welcome back to the Adult Health and Social Care Scrutiny panel. Sorry about the slight technical hitch. And I believe that Health Watch wish to now speak.
Hi there, can you hear me?
Yes, thank you.
Excellent. My name's Karen Huntley. I'm representing Health Watch Kirklees today, and I've come here to speak to you around the feedback we receive about dentistry. Over the past 10 years, we've heard quite a lot of feedback about dentistry, and we have tried along the way to alert NHS commissioners to these issues. So I'll give you a summary of what the kind of things that we tend to hear. We received regular contacts from members of the public around dentistry, and what they tell us is they struggle to access dentistry. Now, some struggle to access routine or preventative dentistry, so that means they can't get access to an NHS dentist. We regularly have people calling us to ask where can they access an NHS dentist, and it's very difficult, stroke impossible, to help them gain access. Others call us to ask how they can access urgent dental care. So that tells us that some people don't know that they can access urgent dental care via NHS 111. So we signpost quite a lot of people to the NHS 111 service so they can access urgent dental care. Where, for example, someone might have an urgent extraction, but then that might need follow-up by a routine dentist and they have no dentist, what we find is we tend to see people making repeat contacts with emergency services to address their dental care needs. People have also told us that where they cannot get dental care, so be that for routine issues, then that can affect their mental health and it can have a great deal of impact upon their confidence. People also tell us that where they do have an NHS dentist, but they haven't attended an appointment for a while, so for example, in COVID, that happened a lot, that they're then taken off the NHS dentist list and then they can't get access again. The information on the NHS Choices website is not up to date, so that's also problematic for people. So sometimes people, when they do have an NHS dentist, there is confusion around their eligibility for free dental care. People may be asked to fill in a claim form, and we've had instances where people with disabilities or people whose first language is not English have been confused by the claim form, and as a result have had fines, which we've had to try and help them sort out. I think that sums up our dental feedback. Do we have any questions?
Yes, thank you for that. We got that, members of the panel, the issues you want to clarify or raise?
Thank you, Chair. Thank you, Chair. My question, you mentioned about patients missing appointments, and if they were NHS patients, they were then taken off the books. Was that actual physically not turning up to a booked appointment, or say during COVID nobody was going to see dentists for routine checkups?
So I think that's a mixture. So some people during COVID obviously couldn't attend the dentist and were taken off for that reason, and others, they may have missed the odd appointment, but they may have missed it for good reason, and then have been taken off the list.
Yes, thank you. The supplementary question to that. Councillor Addy.
Just looking at those, I've got a few people in my area that had lost their NHS places. Do you know what, are you able then to feed in other people? You know, if people come to you about, are people able to feed into those places that have been lost? Because, that's an NHS place that is therefore presumably just sat there empty. Does somebody else come up the list onto it? Is that how it ends up not being available to them? I don't know if I'm asking the right person, or maybe I should be asking in the other direction.
So there were a very long waiting list for NHS care. So we hear of people waiting years. We are very rarely able to help someone gain access to an NHS dentist. I've only been able to do it, for example, in cases where people might need a dentist before they can access cancer care, so in very special cases. So it's not a case of, one person comes off the list and then, the others are calling us able to gain access. That's not, that's not the case at all. Plus those who have been taken off the list are not very happy about it. So often they come to us to try and get us to help them get back on the list.
Can I go with a supplemental, Councillor Armour? So basically what that amounts to is there are no spaces and people are just written off straight away if they've difficulty attending, especially like in COVID where it's not necessarily their own fault.
Yes.
Can I just ask a question?
One more. It's been suggested to me it might be better if we hear a presentation from Hayden, I believe, and then wrap all the questions in afterwards. Sorry, I can't hear you.
It was just about what were the figures for these, how many people are we talking about who have experienced these difficulties?
Yeah, go on then, and then we'll move to this and then come back to questions.
Karen?
So I've looked at our feedback over the last year, and we've had around 16 contacts a quarter. That I would say is the tip of the iceberg. That's the people who know who Healthwatch is and who come to us. I suspect there's a lot more people struggling to access dentistry.
Thank you.
Yeah, thank you, Karen. If you could please hang back. I know we've had issues with the connection, but there may be questions a little bit later on if you're happy to answer them. And now if we move over to the presentation for today, please.
Thank you, Chair. And just to introduce myself, panel, I'm Hayden Ridsdale and I work for West Yorkshire ICB and lead the dental programme of work that's responsible both for commissioning, stabilising and transforming those services. And I think we've had conversation with some of you before, the West Yorkshire Joint Health Scrutiny Committee too. And so I circulated with the papers a slide deck which focuses a little bit more on Kirklees than the general West Yorkshire picture in the paper that we also took to the West Yorkshire Joint Health Scrutiny Committee for information. The paper's got a lot of information there that provide a snapshot overview really of our approach and the progress we're making, whereas the slides provide a bit more specific detail on what that means for Kirklees and Kirklees residents at this point as well. I suppose the first thing I wanted to say was just to be clear that we became the responsible commissioner on the 1st of April and acted really quickly. On the 16th of May, we took a paper through our Integrated Care Board meeting that really outlined that ambition, and that paper is an annex to the Joint Health Scrutiny Committee paper, so you can see the full detail there too. And it outlines the vision that I'll outline for you as we go on. And since that point, really, in May, we've been working on rapidly delivering, particularly our investment plan, but also growing the team and also trying to support the profession to stabilise the care that we do have in place of transformation. I suppose substantively what I wanted to start with was to recognise exactly what Karen has just said from a Healthwatch perspective, really. We recognise all of those challenges, and Karen, you made the point that you've tried to alert NHS commissioners on several different occasions, and just to say that we're really receptive and really want to be having those conversations with Healthwatch, with the panel here today, with members of the public, with clinicians too, and that approach, one of engagement, is one that we're absolutely keen to continue as we've started, really. It's worth me saying that so dentistry is something that we commission once across. Some of the data that I want to share is perhaps only available West Yorkshire wide rather than Kirklees, but I'm more than happy to take questions on that, and I can share that Kirklees specific information wherever possible. There are, as I'm sure you're aware and got from the short presentation Karen just gave, some really significant challenges in dentistry, namely patient access, which is driven by several factors and they're long in the making, really. So it's not going to be a quick job in reversing those things. and there is indeed some national action required to resolve some of those things, namely contract reform and workforce planning, and proper finances for dental services would be the three big things. But that's not to suggest that we can't do anything in the interim time as well. And what I'm going to say to you more substantively hopefully illustrates how we are actively trying to get to grips with that, both in the immediate term and over the mid to long term too. So our ambitions really kind of span the immediate term, the medium term, and the long term. And in the immediate, it's about how do we spend money. So we approved a £6.5 million investment plan across West Yorkshire. That's money that for dentistry would otherwise have been lost. So we're putting that to work, and I'll tell you what that means for Kirklees in a few moments. It also was growing the team, so we've recruited 3 roles to the West Yorkshire team that will add capacity to do the work that's needed to be done. The team was incredibly underpowered before, and giving it the capacity gives dentists and patients the attention that they need to do this really important work. And we focused on building relationships too, whether it's coming to meetings like this or the West Yorkshire Joint Health meeting, whether it's engaging directly with patients. Colleagues might be aware that we're part of something that we call a dental patient reference group, which Healthwatch Kirklees coordinate across West Yorkshire for us, where we can engage with people to hear their thoughts on dental services, how we improve them, the big problems to grapple with, and that's really important to us. In the medium term, it's about how we get to grips with flexible commissioning. So flexible commissioning enables us to make the best of the contract by doing business differently. And our board ambition is to flexibly commission up to 25% of any dentist contract if they meet certain criteria. That delivers services differently for those that need it the most. And also get to grips with oral health as well, and work really closely with local authorities on that, where our responsibilities overlap. And the third of those medium-term priorities is workforce planning. So as I said, that needs some national action, but there are things we can do locally, particularly looking at how we train the staff that we've got, how we make best use of the staff that we've got, and importantly, how we retain them as well. And that's a huge challenge. We need to retain more dentists and the full dental team. Over the long term, it's looking at things like how we transform service models and really support the profession to grow, remain viable. And it's also about some substantive public health interventions like water fluoridation that we've had conversations about, and proper investment in prevention. So in terms of what that means for Kirklees then, I'll touch on some of the data that you've got in that slide pack there. So we've got 54 general dental service practitioners, so that's your high street dentists in Kirklees, that provide up to 763,000 UDAs. So a UDA is a unit of dental activity, and that's part of the national contract. 12 of those providers provide what we call flexible commissioning, and that amounts to 240,000 of those UDAs. So that 240,000 we can really target better towards populations that need it the most. We've got 3 orthodontic providers that provide up to 45,000 units of orthodontic activity. And it's worth saying as well that although there are incredible challenges in the delivery of that activity, we are seeing at a West Yorkshire level an improvement this year compared to last year. So the current delivery rate is sitting at around 83%. It also tends to happen that dentists perform a greater rate towards the end of the financial year, and we're in that period now. So we're seeing an improvement in that position overall. In terms of additional activity, where we've spent some of that £6.5 million in Kirklees, we've got 6 general dental practice providers providing access to urgent care over and above the standard offer. And we've got 5 practices providing what we would call targeted additionality, so for population groups that need it most. So in Kirklees, we've got a practice providing services for homeless populations, for refugees and asylum seekers, for children that live in our highest needs areas, and we've got a practice also engaged in validating their waiting list. And that will enable us to understand the true extent of waits, which I think links to the question that was asked a short while ago. We've also given around £77,000 to the council to engage in some prevention and oral health work. That will look mostly at things like supervised toothbrushing in schools to support children to develop good oral health habits. I'd mentioned previously at the West Yorkshire Joint Health meeting around urgent care and hotspots data, and I've shared some of that in the data pack with you and can share that verbally. So as I said, we've got those 6 providers providing care. What we know across West Yorkshire as a whole is that the level of provision doesn't meet demand, and that's a challenge that we absolutely have to get to grips with. In Kirklees, as in the pack, we think we've got around, on an average month, around 1,000 appointments too few. The really interesting thing too is that that varies then within Kirklees. So our data would enable us to break that down into both the Huddersfield area and the Dewsbury area. And we see that in Huddersfield, access is generally better. It's just over 1 patient per appointment, whereas in the Dewsbury area, you're looking at almost 2. So we'd need to invest in that area there. And then in terms of waiting lists, which I think will be of interest to all, I guess what we see is there are significant ways community dental services and secondary care dental services. Community dental services provide services to those with additional needs in dentistry, whether that's an extreme phobia, a learning disability, or whatever that may be. And secondary care are those perhaps more complex when you're getting into sort of surgical territory. And we've got colleagues here from both that could perhaps talk to some of that too. But what we see in Locala, which is our community dental service provider, is a fairly high level of waits with 1,855 new patients and 331 awaiting extractions. The longest wait's 50 weeks, and the average wait time from being a new patient to an extraction is 77 weeks. In Calderdale, which provides a secondary care dental service, much lower numbers, 135 awaiting assessment and 11 treatment. 49 weeks been the longest wait, and 26 weeks been the average time from new patient to treatment. You've not got data from Mid-Yorkshire in your pack, partly because we had some difficulties being able to separate that out in terms of what of the Mid-Yorkshire patients were Kirklees based and what were Wakefield based, so we wanted to share that accurately, but we do have Mid-Yorkshire colleagues who could perhaps talk to some of the challenges. I think the really important thing when we're looking at that data is firstly acknowledging that there are high levels of need that we need to meet and that we're actively grappling with that. So perhaps colleagues can talk about some of the work that we are doing with community dental service providers to create more capacity, to build links with Trust for Theatre Space, and some of the great work that we are doing to try and grapple with that. As I said, it's not going to be a problem that we can solve overnight, but we are really serious about getting to grips with it and are actively doing that too. And the final point on the wait times, really, and I think this applies whichever services you're looking at, is that they're driven by several different challenges. Some of them are national, some of them we can get to grips with locally, and we're absolutely trying to. That might be staffing levels, it might be rates of patients not attending. It could be a whole range of things, which I'm sure colleagues can cover off a little better than I can. And the final point I wanted to make on the data was around oral health. Now, clearly, access to dental services is incredibly important, but so is the state of oral health. And if you can't access a dentist, then there's going to be an intrinsic relationship there. I have had some slightly updated figures on access to dentists for adults in the last 24 months and children in the last 12 months since I circulated your data pack that were not published, but I've been able to source since. And what that shows is that up till the 30th of June 2023, 55% of adults had access to an NHS dentist in the last 24 months. 55% of adults in the last 24 months in Kirklees had access to a dentist. That compares favourably to the Yorkshire and Humber average and the England average. The Yorkshire and Humber average is 49%, England average is 43%. And children, which is in the last 12 months, 63.6% of children in Kirklees had access to a dentist. Again, that compares favourably to the Yorkshire and Humber and the England average. The Yorkshire and Humber is 59.4 and England is 55.8. So relatively good rates compared to the regional and national averages, but clearly we want to be growing those numbers through the work that we're doing. And the other data in there is around, which is indeed right, in the pack that you've got, in 2019, 31.2% of children up to age 5 in the region had visibly obvious experience of dental decay, which highlights the problem that we're dealing with. I suppose the final points I would make is that, and hopefully that's articulated here, and really happy to get into that conversation, is that it is incredibly hard what we're dealing with. We've been the Commissioner now for about 10 months, and we've spent the £6.5 million across West Yorkshire in the ways that I've outlined in Kirklees, which is important. We're actively planning for how we do something similar next year. That £6.5 million is driven by under-delivery of contracts, and we need to put the full dental budget to work, and that remains our commitment. we're actively looking at how we implement the new flexible commissioning programme and those things. We're really committed to doing that by working with people, ultimately, the people that have the answers and creating those solutions together, and that being clear that there are some national levers that need to be pulled in. Particularly would want to acknowledge the letter that went from the West Yorkshire Joint Health Scrutiny Committee to Secretary of State that covered those matters. So I can pause there. I'm not sure if any of my colleagues would want to add anything specific, but I'll hand back to the Chair. Thank you.
Yes, thank you for that. First of all, just for the benefit of people watching on YouTube or otherwise, it appears we've got a problem with the cameras, so the cameras are not always focusing in the right place. I can only apologise for that. Moving to Mid-Yorkshire, do Mid-Yorkshire people wish to add anything? Because I am concerned, one of the concerns of this panel is health inequalities. And there appear to be inequalities here between Huddersfield and Dewsbury, to put it into broad terms. Is there a reason for that? And up to you.
I think you can hear me now. First time I've worked this. Okay, hi, I'm Mark Smith. I'm Deputy Director of Operations for the Division of Surgery at Mid Yorkshire NHS Trust. Just to give a very quick overview of our service might be helpful in terms of context. So we provide a secondary care oral maxillofacial service, which is across the patch in terms of Wakefield and Kirklees. We do provide a community dental service only, but that's for the Wakefield patch. And then we support our colleagues in Locala, historically at least, with access to theatre at traditionally it was our Dewsbury Hospital site, certainly pre-COVID. Obviously after COVID, that's been a challenge to reset up, partly because we don't do paediatrics on our Dewsbury Hospital site anymore. So we're working with colleagues now to provide that sort of service going forward. But I think that hopefully context in terms of where we're at, because I think a lot of the conversation that I've heard has been around sort of dental treatment, and that's not necessarily something that we would get involved in at Mid Yorks. We're predominantly a secondary care dental service, but hopefully that's helpful. In terms of waiting times for oral surgery, happy to answer any questions around that. If there's anything sort of specific you want to ask me, I'm happy to take questions.
Yeah, thank you for that. Any of your colleagues wish to add anything? Right, thank you for that. Well, you say you're happy to take questions, so Councillor Munro, you wish to ask questions.
Thank you very much, Chair. So you've invested 6.5 million. Is this investment going to resolve the issue of a lack of dental nursing staff required for theatres for dental extractions for paediatrics? I noticed locally you've got 331 paediatric patients waiting for extractions. How many of those are waiting for surgical extractions in hospital theatres? And I've noticed Calderdale and Huddersfield, you've got 11. Just wondered how long those patients are actually also having to wait. Thank you.
So I can take the questions generally, and then in terms of Locala input, I'll refer to Locala colleagues. So in terms of the £6.5 million and whether that includes any scope for dental nursing staff, so it's not got an immediate investment line, if you will. Where we would be picking up that work is through our work on workforce, and that's being led through people that have expertise in workforce planning. And to give you a couple of examples, so we're focusing on what the priority staff groups are that we need to recruit more of and retain more of. We're working really closely actually with the University of Huddersfield, so they're actively pursuing a dental hygienist course that they're hoping to get up and running in the next... Sorry, my microphone went off. So we're working really closely with them to ensure that the course they're designing firstly gets enough people through the door, but also that it meets the need of the dental workforce too. And that's hygienist, not nurse, but that gives a flavour of how we're trying to work on those things. Sandra or Rachel, I don't know if you want to add anything on the Locala aspects.
Yeah, I'm happy to pick that up. So from a secondary care element, from when we send through to general anaesthetic, the difficulty that we face is the access to the theatres, and then it's the clinicians. The dental nurses is not necessarily an issue. We tend to have enough dental nurses. We are always looking at workforce with that, and we are looking at different ways to bring new workforce through across that patch, including dental nurses, but we don't perceive that to be an issue within Locala. From touching on the point that the gentleman made about health inequalities, we've not had that health inequality expire itself. We have continued to take people across the population, and they've been serviced through CHFT. So despite Mid-Yorkshire's theatres being out of action, we have not been taking just Kirklees residents in South Kirklees. We've been taking that across the patch to make sure there's that equity as much as we possibly can do. The dental hygienist course that Hayden just spoke about, our clinical director, who would have liked to have been here today but unfortunately couldn't be with us, Balkeesby, I think she presented at the last Scrutiny panel. She's heavily involved with the development within that dental hygienist course, and she represents nationally across the footprint in the dental. So we're really excited at the new workforce challenges being addressed as we move through and working together in much wider collaboratives, including that university space. So I'll leave that there because I feel like I might be going off on a tangent.
Yes, thank you for that. Any further speakers? Right, thanks for that. Karen, you...
Sorry, can I just come back with a supplementary, Chair? So can you just answer then, how long are these paediatric children who, paediatrics who are on your waiting list for surgical extractions, how long are they having to wait?
Yeah, that was in the presentation. So we've got waits of over a year at the moment in some areas. That is partly historical because of the inability to deliver dental extractions for the whole of the COVID period. So we don't have the theatre space to be able to catch that up. So we're working through it slowly. It's not necessarily access to clinicians or nurses. It's physical theatre space that is the kind of restriction on how much activity we're able to do at the moment. But we've had some additional funding through, as Hayden's talked about, which is helping with that. So we're gradually making inroads to the historical waiting lists. There's a secondary problem to this, which is part of the wider work, which is because there is a lack of general access to dental services. What we're finding is that some, particularly children and some of the other groups that we support through the specialist service, they're coming into our service when actually with a little bit of additional support they could be managed in general dental practices, but that access isn't there. So we often find that we get people through into the service that could have been managed in primary dental services, which is why we're looking at providing additional support around education, particularly where we've got populations with health inequalities like people with learning disabilities. So we're trying to provide support back into the community so they can better manage people in a more appropriate environment. So again, that is a kind of longer term piece of work that we're doing to support our general dental colleagues as well.
Thank you, but that doesn't actually resolve the issue of children who require dental extractions in a theatre.
Could I pick that up as a response? So we've had access to the CHFT theatre since April 2021. So since COVID, we had access prior to that in both Mid-Yorks and within CHFT. That obviously shut down, and we worked really hard to reinstate that. So we've had that access in CHFT since April 2021. Because we're not part of the elective care programme, we get the theatre slots that are given to us, and we can't really bargain with that. So we've had consistent slots with CHFT since April 2021, and we service and furnish that every single week. We've had an extension to that, so we now have got additional day that we're going in there, so we're looking to expand that all the time. As part of the collaborative, which I think Aidan will explain a little bit more about in a second, we're working closely with another CDS provider in West Yorkshire and looking at how we can put an integrated pathway in so that they can start to take some of the children that we've got waiting through their theatres, and that's kind of just really the starter of that collaborative work. So we are seeing some movement on that, and we are working that through. And as Mark alluded to, we're at the beginning of conversations regarding the Mid-Yorks and what that would look like. We've got a really innovative way of addressing that. Whether that comes to fruition or not at this time, we're not able to say. However, we're quite ambitious with that. And if it comes off, then what we'll be looking at is a really, really big piece of work where we can get quite a good number of people coming through that system consistently. But we're still at the beginning of working out what that means from a financial position.
Yes, thank you. Abivan.
Thank you. It's just a follow-on question from Councillor Munro. In terms of your waiting list, you've indicated that it could take up to a year for some of these children that are waiting for extractions. Do you have any data of how many children might turn up at A&E wanting sort of emergency care? And if they do, then what are your next steps? You know, do you fast-track them, or do you still continue with them on the waiting list until there's a next available appointment available? If you could allude us to that, please. Thank you.
Sure. I'm happy to come back on that, and if I can cover part of the previous question too. So I think the fundamental thing here is, as you've said, we've got children waiting for up to a year, but at what rate will that waiting list continue to grow is also the question. And we're doing some work now, again, with Sandra and the other community dental service providers across West Yorkshire to understand, firstly, what's caused the growth in wait. Is it, if it's a pandemic response, let's say, can that pandemic bubble be burst is sort of the question. If it's a broader problem that there's not enough staff in the places to service the need, then there's a bigger question and a longer term solution there. So we're trying to do that understanding. And as Sandra's also said, there are those kind of collaborative mutual aid style of conversations between trusts to say, can we have some of your theatre space, and so on and so forth. That's really, really important. The other thing that we're doing as well is we're in the process now. We're reviewing the community dental service specification and model. We're working with all of the providers to design something that would better meet population need and reflect the fact that, as both Rachel and Sandra have said, that if you can't access a dentist perhaps in your local community, by the time you get to the community dental service, your needs higher, the complexity is higher, which poses a challenge for that service. So we're actively trying to grapple with that. In terms of your question about children that are also showing up to A&E, so I don't have data that shows the children going to A&E versus the adults, but what we do have is some data that shows that in the year and a half prior to September 2023, in Calderdale, we had around 2,000 people present to A&E with a dental-related problem, and in Mid-Yorkshire, around 4,000 people. I think what that represents is frustration from people that they can't access services where they best have their needs met, and that there's a cry for help there ultimately. So we are really serious about thinking about the solutions to that, and already signed up through our clinical leadership groups that we try and map that data backwards to see who those people are they children, are they from a particular area, and do that work and work on that in a more innovative way as well. So we're absolutely in the space of dealing with that. We just need to fully understand where that comes from.
Yes, thank you. Helen.
Can I just ask a...
Oh, go on.
So, in terms of the data that you've shared, I mean, it is very, very high. I mean, it's shocking, really, that that it's so high. So, are those that have gone through to A&E, are they part of an NHS dentist, or are they on a waiting list? Do you have that data available? Again, we often hear that people can't get access to a dentist, or they're not on the waiting list for NHS appointments and things.
Yeah, and I don't know what the data will be capable of showing us when we track it back, but we can ask those questions of the data. The thing that will complicate it, to be really clear on, is, as I'm sure you're aware, patients don't register with a dentist, say, in the same way that they do with a GP practice. It's the responsibility of that practice to manage that waiting list and deal with that. But we can absolutely work with practices to understand what's going on in that space. And I think the other thing, just to touch on, that you were mentioning is, there will almost inevitably be some people within that 2,000 and 4,000 figure that are double, triple, quadruple counted because they've perhaps called 111 and the appointment's not been forthcoming and they showed it to A&E and those sorts of things. So we need to understand the true extent of the unmet need there, and that's a piece of work we're actively looking at.
Yes, thank you, Helen.
When we met with your colleagues, I think it was about a year ago, they said that the main issue to paediatric services and extractions was lack of availability of the theatres, which is exactly what you've just said now. Has anything changed in that time? Because I find that quite shocking that that was, you know, it was headed as a main issue. And the reason that you've given, which was that you don't have access to that and that's not your decision, I find astounding that that hasn't been escalated to anywhere for that to then be given some credence and some availability. And it's really disappointing that it's exactly the same as it was when we met with you a year ago.
Hi, it's Catherine Wormstone, Director of Primary Care, Kirklees Place for the ICB. I think I was listening last year when colleagues came and I think we were all a little bit concerned, weren't we, with some of the data that had been reported, but wanted to assure you that it absolutely was escalated. And I know a number of discussions took place, follow-up discussions both with Mid-Yorks and with CHFT. So I think what I'm hearing from our Locala colleagues is that position in CHFT is there and is improving. And I think Mid-Yorks have explained that they're working really hard to try and improve their access to theatre space. However, I think there are some site-specific issues that they've alluded to, particularly around the Dewsbury site and paediatrics. So I did just want to give you that assurance that, yes, it absolutely was escalated and it's been discussed a number of times since.
I think it's just difficult to hear we're working towards, we've put some work into, we haven't got any by this time, this will have improved. Since last year, this has got better. And that's really difficult to hear, because as much as I appreciate that a lot of work is ongoing and people are trying really hard to improve things, it doesn't feel like that's actually coming to any fruition, that people are having access to dentists, and particularly children are in pain for months on end before they can get to a theatre.
Sorry. Yeah, I don't know whether colleagues would want to pick up on that, because I know they've talked about certain initiatives around Mondays and trying to look at creative and innovative access to theatre space to try and improve that position. So, do you want to come in on that?
Yeah, happy to provide some additional context to that. So we don't currently provide any paediatric services for admitted patients, so patients requiring theatre, at all on the Dewsbury site, and so that's the main challenge that we have. We have all our paediatric services centralised at the Pinderfield site, which is about 11 miles away, so it means additional travel for those patients, and that is an option. So we. Sorry, I won't try and compete with the drilling.
Yeah, well, unfortunately there is some maintenance work ongoing.
Obviously some renovation works perhaps taking place in the town hall. Yeah, sorry, I was adding some context to some of the challenges that we're trying to work through and perhaps why it's taken as long as it has so far. So yes, we don't currently provide admitted paediatric services on the Dewsbury site. So they're all 11 miles away on our Pinderfield site, and that is an option. So we can provide that, albeit it means more travel for those patients. But what we're actually trying to do is look at how we can use our Dewsbury site differently. So the main challenge we have is we have one elective surgical ward on our Dewsbury site, which is currently for adults. We don't mix pathways, so that's why it's challenging. So in order for us to do paediatrics, it essentially means that we have to stop doing the adults and flip the capacity to paediatrics. So that's the plan we're working up at this moment in time, and that would look something like we would do what we the terminology, but super days, paediatric days, however you want to sort of phrase it. But But essentially we'd have a Monday, for example, whereby we'd be able to convert all our theatres dedicated specifically for paediatrics. And that allows us to actually catch up quite quickly in terms of the workload. That's much more capacity than we'd normally provide. But in order to do that, it means we have to schedule our adult electives the week before carefully, so day case patients leading into the weekend, essentially close the ward down over the weekend, clean it, turn it round, get it ready to then obviously then manage paediatric patients on the Monday, day case patients, and flip it back to adults then on the Tuesday. And we could do that maybe once a month, once every couple of months, depending on the demand in terms of what we need to do. But that's the complexity behind why it's not just a quick, we can turn it on and that's it, fixed. But hopefully that's helpful.
Yes, thank you, and thank you for battling through the distractions. Councillor Addy.
Hi. I know we're specifically focusing on the paediatric surgical need. However, what underpins that is the lack of NHS appointments in the first place. This backlog does not clear itself when you're getting people coming to you in emergency states, when people have been waiting so long. So I need to know whether these people are actually coming from NHS referrals. Are they actually coming through the system? We do need to find out where they're coming from. And I suspect that they're actually coming in at that point, or from an emergency dental appointment that's pumped them full of antibiotics to put them on hold till they can have this. Until we can actually effectively get people into dentists to have the basic NHS care, learn to look after their mouths with regular appointments and advice from the dentist. Under fives at this level with decay, you know, because they're not getting led into that regular habit of going to a dentist and practicing. Earlier treatment means less treatment. More effective treatment means less pressure on these high-end services. So it's great that we've found some ways to get some more of them in, but that tidal wave is going to keep coming. So when are we going to see more NHS capacity in our area and staff and facilities, and when are we going to be pushing for the money to make NHS services a reality in dentistry in our area, across the country hopefully, but in our area? We keep talking about the tip of the iceberg. There are people out there suffering, and it's not just about mouth and oral health, it's about those knock-on effects, the rest of the body, and mental health. It's putting massive pressure on other services. The cost of actually providing these NHS dentists could probably be mitigated by the lack of need for heart, as has been linked to dental health, mental health, and then these high-end services that could maybe not have been needed if they've been dealt with. When are we going to get some more NHS capacity for proper, ordinary, everyday coming into dentistry?
Thank you. Yeah, so I completely agree and completely recognise those challenges. There's a couple of things to touch on, perhaps answering part of the previous questions too, is that I just scribbled down. But you're right, the lack of the inability to access a dentist in the first place leads to deterioration, leads to increasing complexity, leads to more time being spent when you reach the sharp end of care, shall we say. And we have to address it early, and we also have to properly resource the services at that sharp end too. And they're the conversations we're having. I think there are... Let's try now. So there are a few things I'd pull out and completely recognise the frustration around when are we actually going to see some progress, when's it going to be tangible. I think Mark and Sandra and Rachel have given some good examples of tangibility where the rubber is starting to hit the road now, which is great. I think the other thing that I'd say is we have built in the 10 months we've been the Commissioner, I think an incredible amount of traction, momentum and speed behind this agenda, putting it in our top priorities, and having additional resource working on this is really important. Without the people, we can't do the work ultimately. And I think that's us showing that commitment, and going into next year, we need to continue delivering on that commitment, and we're absolutely committed to doing that. In terms of the question you were posing there, really, how and when are we going to improve access to general dental practice, really? Firstly, I think it's important to say that in the Joint Health Scrutiny Committee letter, it does cite finances as a particular challenge, along with workforce and contract reform. And so those solutions do sit nationally. What we're committed to doing is continuing that discourse nationally and continuing to influence to maximise our budget, as well as putting our money to best use. And we know that a lot of the dental budget, a proportion of does is underspent, and that 6.5 million represents us trying to absolutely spend that. There's a couple of things we can also do which are quite innovative. One of the things that dentists tell me a lot is that the sort of scary thing from a dentist and business perspective is when a patient sits in their chair, they don't know what's going to happen when they look inside their mouth and do that examination. So how can we support dentists to do that? And we could look at and having conversations around a sort of dental pathway that would enable that. It's similar to the urgent scheme, but it's not only about urgent care. The other thing we can do is we can upskill practitioners at that general dental practice level, and we've got a pilot program ongoing at the moment that we would call level 2 paediatric dentistry. So this is patients that would ordinarily be sat on a community dental service waiting list that are children that could be seen in general dental practice if the staff were trained appropriately. And we've got a training program for that, but we've not been commissioning services in that way. So we're seeing how that works at the moment. If that's successful, works well, and we can get the dentist upskilled, then that's the space we should be in commissioning services at the lowest level possible. And the final point, I suppose, in fact, two final points. So one is on oral health. You're absolutely right. There are several links between oral health and cancers and heart disease and those sorts of things. The solution lay in the same space, and therefore we have to improve that link with oral health teams and local authorities and get serious on how we commission those services and do things like outreach work, like the supervised toothbrushing that the Kirklees local authority will be doing with the money that we've invested. And the final point I was going to make was we were asked a really similar question at the Joint Health Scrutiny meeting of when we were going to be able to offer some specific information, and we agreed, as we already were, that we'll be developing a more specific plan than perhaps we had for this year. This year's priority was stabilise the system, recruit more people to the team and spend £6.5 million, and we've absolutely done that. How are we now going to attach timelines and rigorous plans to those things? And we already committed to sharing that through the Joint Health Scrutiny Committee when those things are ready. So perhaps that can find its way through chairs and things.
Just to come back on that, please. So you mentioned a trial of upskilling practitioners. When does that trial end, and when can we see something from it? And you mentioned talking to the West Yorkshire JOSC about specific information. What's the timescale for getting the information back on that, so we can actually see some idea of real numbers of extension of NHS dentistry from the basic level up? This is great. We need to deal with the surgical, we need to deal with the emergency, but they're just going to keep coming if we don't start people off from scratch. The dentists, you say, the fear most is that they don't know what's in the mouth. When people having regular checkups, they know what's coming. You know, there's not that much to surprise them.
No, absolutely. So in terms of the timelines attached to the work that we agreed through JOSC, what I'll need to do is take it away to actually see about the scheduling of the JOSC meeting, because it's not something that I'm personally responsible for, but I can absolutely have that conversation. In terms of the upskilling of the workforce, so we've got a 12-month pilot program that's running from January, just started, up until the end of December. So we'll know really how it's going by the end of that, but we've got sort of check-ins built within that. We also have, and I'd need to ask with colleagues that are running this, so the practitioners we've commissioned through were part of the first cohort of level 2 trainees, if you will. There's another cohort that's coming to its end sometime soon, and they'll need to go through an accreditation process, but that will enable us to see the kind of pool of talent that we've got to work with if indeed this 12-month pilot is successful.
Yes, thank you. Now I'd like to return to this side of inequalities, because I am worried about it. On the face of it, on the face of the paper, on the figures you've provided or we've been provided with, it seems to be that there's a very marked imbalance between North Kirklees and South Kirklees. Dewsbury, Huddersfield, roughly speaking. Because of the demographics of Kirklees, there could be cultural factors in play there, or it's just possible it's just geographical factors. But I would like the panel to be given a bit more information about this. I'm not sure exactly which one of you would be. I'm supposing you will, Hayden. But I would like the panel to be given some clarification on this, because it does worry me. It doesn't seem on the face of it to be fair or equitable. Thank you.
Yeah, no, absolutely. And as colleagues will be well aware, tackling inequalities is one of the big priorities of integrated care boards generally. So that threads through absolutely everything that we're doing. And that equally applies to dentistry. And we've reflected that in part by commissioning bespoke services for homeless people, for refugees and asylum seekers, for children living in our highest needs areas. Effectively, what that reflects is that we've used the best data we've got available to make a judgment call on where need is the highest. And we know that children in our most deprived areas is one, we know that homeless is one, we know that refugees and asylum seekers are one too, hence commissioning those services. What I would also say is that the data is not as complete as perhaps it would be in other parts of the health system. So there have been some inferences that we've had to make. Generally, the indicators of poor health, poor access, poor outcomes are the same across the board. And so that's the evidence base we've used. And we're also actively doing a piece of work, again, working with the local authority public health teams and our public health consultant at the ICB to understand how we actually improve that data too, both bringing data sets together, but also creating perhaps new data that we do need to measure, because you're absolutely right, there's a difference. And what I could also share with colleagues after this meeting, perhaps through other colleagues, is a slightly more detailed breakdown of the wards that practices are in too. I didn't have it in time for this meeting. It may also not be all of the wards that you'll be familiar with, the geography of Kirklees, but it is slightly more granular, and therefore it may draw some conclusions. And the most important thing is, if there are obvious gaps, then we're committed to using the best evidence we've got to address those gaps through additional activities.
Yes, thank you. I'll ask the committee officer to liaise with that. Thank you very much. Right.
Hi. So you spoke about the rapid delivery of your investments of 6.5 million in May. So in terms of a patient journey, what does that look like? So somebody from Kirklees, say Dewsbury, wakes up with dreadful toothache in the middle of the night on a Saturday, early hours of Saturday morning. Is there assurance that that person will be able to receive urgent care? And how is that different? Is it different to what it would be 10 months ago or a year ago? I suppose from a patient journey, what change has the investment made, in real time?
Sure. And so it differs based on what scheme we're talking about. So I'll take urgent as the example that you gave. The fundamental difference we took through the decisions that we made was to extend that for the duration of this year. Without extending it, that system would have effectively disappeared. So we took the decision that we would invest our resources in continuing that urgent system. But as I said earlier on, what we know is that across the patch as a whole, we've got about 1,000 appointments less than we need. And that's not just a Kirklees issue, that's right across West Yorkshire. The challenge is, as we've been alluding to, the market, if you will, of dentists is facing serious challenges, and so getting them engaged in that it can prove difficult. So we're doing work on that. But if somebody wakes up with a toothache in the morning and they call 111, then that system has an inbuilt clinical triage to sort of prioritise patients, and they should be offered an appointment as soon as possible. If we took an example of, say, the homeless scheme, one of the more targeted schemes, the way they work is we work with voluntary sector organisations to physically get the person through the door and in the chair. So we'd use that voluntary sector organisation's expertise in outreach and communication to support. There was a figure that I'd seen across West Yorkshire a short while ago that the homeless scheme specifically had created around 450 additional interactions in the dental system that wouldn't have otherwise been there. So that's 450 interactions of dental care that wouldn't have happened. Those figures would have changed by now, but that's the kind of...
And that's great, and that's really good to hear. But what about, I'm not going to use the word ordinary, what about Joe Bloggs? I've just got intractable dental pain. I can't get an urgent appointment. I go to A&E, and then what happens to me? And is that different to a year ago or 10 months ago?
Yeah, so as I said, by extending the commissioning for the full year, it ensured we had it ensured we stabilised what we already had.
So are we talking about maintaining the status quo at the moment?
There's a stabilisation question, and then it's how do we stabilise and build on through the additional investment. So we've stabilised. We also, as part of that investment plan, did look to sort of ring fence some monies for expanding that. And to give you just one example that comes easily because the period's just passed. Ordinarily over the Christmas period, the provision and availability of dental care decreases, bank holidays and that sort of thing. We spent an additional pot of money right across West Yorkshire to ensure that a safe level was maintained too. So in that's a 2-3 week period, but that gives you a snapshot of how we are stabilising but also investing additionally to create additional capacity. But we know there's far more that we need to do as the data shows us.
Okay, thank you.
Karen, you've been very, very patient with me, and thank you very much. Have you anything you'd like to either add or any clarification you'd like to seek?
I would just like to make it very clear for the general public, access to routine dentistry remains very difficult, and that impacts. That also has mental health impacts for some people. You know, it's incredibly difficult, stroke impossible, and you've got people where they can afford to go in private. Some people are considering going abroad, and then there's lots and lots of people who cannot even consider that. So I would say access remains incredibly difficult.
Yes, I think, just a moment. Anybody wish to take up and comment on that, about the access, etc.?
I think, Chair, beyond what's already been said, it's just acknowledging that we're taking that incredibly seriously, and it's the driving force, really. It's stabilising the access we do have, but it's building on that as a top priority for the ICB overall.
Yes, thank you. I'm not sure whether I've still got Karen. If you're still there, Karen, would you like to have a supplementary? Ask anything else?
I am here, yes. I think what's also really important is communicating this to the general public. So a lot of the public, for example, don't know how to access urgent dental care through NHS 111. So where there is a service that's available, I think it's really important that people know about it.
Yeah, I couldn't agree more. I think the immediate opportunities we have are working through, as I said, the dental patient reference group to actually understand what messaging patients do need that Healthwatch Kirklees are leading on with us, and equally the support that elected members in conversation with their constituents can give in terms of the conversation with patients. And as colleagues will be aware, we agreed to provide updates to all the chairs of the scrutiny committees on the work that we've been doing, which will include some key messaging that might support those conversations too.
Yes, thank you. That's it, Karen, for you. Is that it? Anything else you wish to comment?
Sorry, having trouble with the tech. What I would say is Healthwatch Cross West Yorkshire are now working very well with the ICS regarding dentistry, so I think we have to acknowledge that as well.
Yes, thank you for that. Councillor Lawson, you wish to ask a question?
Thank you, Chair. I note that there has been some improvement in the percentage of children that have had access to an NHS dentist in the previous 12 months. It was 54% in 2019, and in the last 12 months it was 63%. But we've still got to realise that is still over a third of children have not had any contact with a dentist. In the figures of the 63%, is every contact that a child would have in those figures, i.e. they might go for a routine inspection appointment, they might go for a filling, they might end up having to have emergency care? Is it all lumped together? And if so, is there any ability to differentiate between the child that's not got the access to the routine inspections and he's just turning up when it is an emergency somewhere? And also, have you got any up-to-date figures about the percentage of 5-year-olds that have got tooth decay? Because obviously in 2019, that was a third of all children in Kirklees. Thank you.
So on the point of how that data is counted, I can ask our dental public health colleagues exactly and provide clarification through the Secretariat if that would be helpful. And I suppose it's recognising your point that the increase is good, and I think that we'd absolutely all welcome that, and I think we have to recognise all the hard work of our dentists that goes into that. And I think through working with them and creating the hope that we are to improve dental services gives them greater confidence as well. So I think it's good progress, but acknowledge and agree with your point that that's still a significant amount of children not accessing dental care. And in terms of the decay figure, again, I'll seek clarification from my dental public health colleagues. The thing to bear in mind here is that data would primarily be collected through what we call an epidemiology survey. And there are national challenges in the implementation of that and local challenges too. So we might struggle for more up to date, but I will ask the question and see if we can provide clarity.
Yes, thank you. Anything else?
No, thank you, Chair.
Right, I think everybody's had a chance. Oh, Councillor Ali, very quickly.
Just a very small point, but we're looking at that. 2/3 have had some access to dentistry. 1/3 of under 5s have dental decay already. That's 100%, isn't it? That's what's happening to that third. It would appear from the stats there, the third have got dental decay by the 5 years old. We really need to catch them.
Yes, if any of our contributors would like to comment on that, we do really need to catch them. Perhaps you're not quite casting the net wide enough.
Yeah, no, we completely agree that that's how it looks, and we need to interrogate the data far more, and at the very least, create more access for people that need it the most. So, yeah, completely agree, and I suppose it's just to acknowledge that I think we've made good strides in the past 10 months. Hopefully, colleagues sat behind will attest to that in terms of the work we've been doing together, and also recognise the hard work of all the organisations and dental practices that are in Kirklees providing services to do that. We recognise there are absolute challenges that we have to get to grips with and are trying to, but that trying, I think, is really important.
Yes, thank you. Councillor Smage, would you like to contribute?
Yeah, thank you. I could never observe a meeting. Just the West Yorkshire JOSC has been mentioned, and part of the recommendations from that, because the paper for the West Yorkshire JOSC is a strategic across West Yorkshire, and obviously the Kirklees panel will be looking more detailed into Kirklees. But part of the recommendations from the West Yorkshire JOSC is that committee has some information on timeframes for the ongoing plan that you've mentioned, hotspot data and progress being made on increasing communication and workforce plans, and that 6 weekly updates on progress on the vision and plans for the future be circulated. And that the Chair and Deputy Chair write to the government on the National Dental Contract. So obviously when things come through for the West Yorkshire JOSC, we can circulate that to the Kirklees panel as well. We did write to the Secretary of State about reviewing the new contract, asking that it move forward at pace, and that it be supported by clear long-term workforce planning and financial arrangements within the context of the overall public expenditure. So a letter was sent. But Chair, with your permission, I would like to sneak a question in to Mid-Yorkshire. I would like to understand whether, from the Wakefield perspective of their operation, whether there are similar weights for dental services in Mid-Yorkshire to the North Kirklees side of things.
Yes, I believe there is. So our longest waits are currently just over a year, similar waiting times, but we are making really good progress actually currently. So the waiting times are coming down all the time, and we're heading in the right direction. Obviously, from a national RTT, what we call referral to treatment point of view, there's some key targets around that, and we're on track from an oral surgery point of view to deliver those targets.
Okay, so my supplementary then is, if you've got similar waiting times for Wakefield, what capacity are you working on to put into your services? And if you're saying that you're going to open a theatre at Dewsbury maybe once a month or maybe once a couple of months, how many months or years are you going to get that backlog sorted out? What are your estimates?
Yeah, so from that point of view, we're essentially a provider of a service to our colleagues in Locala. So the patients that we're talking about are obviously the Locala community dental patients. So we just provide a theatre, but clearly we recognise that without providing that theatre, your options are limited. So I'm aware that, and perhaps colleagues in Locala want to talk to this more than I can, but I'm aware that they do have other options in terms of theatre, and obviously we have other options within our trust. We are working together to find a long-term solution to this. Okay,
it's just that Mid Yorkshire is there for Wakefield and North Yorkshire, North Kirklees, to serve Wakefield and North Kirklees people who need the surgical interventions, and therefore I was wondering what your plans were to put capacity into the trust. Thank you.
Right, I think my panel have all said what they want to say and asked the questions. Councillor Ramsey, would you like to say something?
Are you going to allow me to ask a question, Councillor Almer?
As long as it's not political.
It's not political. I was really interested in the discussion about access and about how far people were actually having, well, and it was around the children, how far children are having to travel. And I might be wrong, so I'm hoping to be corrected. Are children having access to theatre sites on the Calderdale site or the Huddersfield site? So I'm just checking that one out. And I did find it a bit interesting, Mark, when you came back with it's 11 miles to go from Dewsbury to Huddersfield, because when you want to move services to Pinderfields, it's very easy for our population in the kind of like Dewsbury-Batley corridor to tram across to Pinderfields. So I'm just making that point. What we don't have is a timeline yet for the Mid-Yorks, for a resolution for Mid-Yorks, and that would be interesting to hear that. So that was my first one. I thought it was really interesting, the discussion about urgent dental care and access to urgent dental care, and it didn't seem to be brain surgery to me to think, well, if you've actually got one person around accessing dental care in the Huddersfield site, and you've got half the size of the people accessing A&E, the potential, and two over at the Dewsbury site and twice the number accessing A&E through Mid-Yorks, it could well be that there's a correlation there. I did think about that. But I thought the questions about routine, access to routine UDAs and when are we actually going to see those improve, and that will then feed through. I thought they were very good. So thank you, Bill.
Thank you.
Do you want me to respond to some of that?
I was just wondering if somebody was going to volunteer.
Yeah. So regarding the CHFT question about where the GA procedures take place for Huddersfield patients predominantly, historically that was at Huddersfield Royal Infirmary in their day surgery unit, but that closed down post-COVID. So we now operate from Calderdale Royal, and that's where all our patients across Kirklees, I want to bring that point in, it's not just the Huddersfield patients that go across to that site. So that's where we operate from currently. Regarding timescales from a Mid-Yorks point of view, that is early days about that discussion, about what that might look like from a theatre access point of view, and obviously Mid-Yorks have had their challenges regarding their facilities, so we're working through that and hoping to agree some timescales in the next few weeks. Mark?
Yeah, I think that's fair to say.
Yeah. Does that answer all of your questions?
Yes, I think my point was it's not easy to access, is it?
No.
If you live in Kirklees, particularly if you live in North Kirklees, if your only option is Calderdale at the moment, yeah. And it's possibly, well, we'll leave it there.
Thank you.
Could I just pick up part of a response as well, just recognising that the thing we're dealing with here is not only access to services in the physically in the door aspects or oral health, it is the means by which a patient gets to meaningful treatment, whether that's a taxi, a bus, a service of some description, and indeed translation services as well. And so as part of that investment plan, we did put a proportion of that resource into what we would call structural barriers or enablers to accessing care. And so I think it's important that we continue to take that seriously, that if we are asking patients to travel, are there arrangements, firstly, on a trust basis that can be supported, but then is there any additional support required, whether it's translation or transportation, whatever that looks like.
Right. Thank you very much to all partners for your contributions and for turning up and answering all these searching questions. Thank you. I'll have one of my officers contact you about the inequality issue. Yeah. Right. So if you wish to go, please leave quietly. Thank you. Right. Next item is the work programme, item 7. What we got for this?
If you just want to have a quick look at your work programme, we're working through it quite nicely. And for the February meeting, we currently have 2 items on there, which is the Adult Social Care CQC Self-Assessment and Development Plan, and then also the Kirklees Safeguarding Adults Board Annual Report. Now, the proposal is to add additional item on that, something that's come out from the West Yorkshire Joint Health Scrutiny Committee. So with Councillor Smage being the chair of that meeting, she might just want to give you a quick overview of that item that's come out that we want to add on to the February meeting.
Thank you. The West Yorkshire Joint Health Scrutiny Committee had an item at their last meeting on non-surgical oncology. This does not include radiography. It is, and it for more complex surgeries, so the tertiary services for cancer continue for Leeds. But this is for breast, colorectal, lung and prostate cancer. They would have their routine cancer treatment at their local hospitals. But if they were acutely unwell, then they would, if they needed inpatient services, then the proposal is to have a north and a south of West Yorkshire provision for inpatient services. This is for non-surgical, so surgical are out of scope. This is non-surgical. So the proposal is for the Wakefield, Kirklees and Calderdale for the inpatient services to be within CHFT. They are opening some beds at Huddersfield, but it will be for the reconfiguration as to whether they remain at Huddersfield or they remain at Calderdale. At the moment, that isn't clear at this moment in time. And for Bradford, Harrogate, Craven and Airedale, then they would have inpatient services at Leeds. Okay. Currently, Mid Yorkshire area patients, for non-surgical oncology, if they need inpatient services, they're currently going to Leeds at this moment in time. So they've done some engagement work around this, have the ICB, and they held 9 community-based public engagement events across West Yorkshire and Harrogate, and the venue within Kirklees was in North Kirklees. And they also had 2 online sessions via Zoom in August of this year. They then had a second phase of engagement in 23-24 and have engaged staff as well. And it is whether this panel would like more information on this change of service and the impacts for Kirklees, and also whether you would want to have any detailed information on the engagement that took place within Kirklees, what that was and what questions were asked, etc., and what the responses were, and whether the panel would then want to make any recommendations to the ICB. The ICB has to make a decision as to how they're going to proceed with this proposal, as to whether they would go out to formal consultation or not. At the moment, the group that have been looking at this are saying that they don't believe that they would need to go to formal consultation. But the West Yorkshire JOSC did say that it was for each place panel to decide whether they felt that they needed more information and whether they wanted to see more engagement or consultation for this item. Okay.
Councillor Lawson.
Thank you, Chair. I was just wondering, Councillor Smage, did they give any detail about how the patient's care would be managed? I'm assuming that the patient from Wakefield would have a Mid-Yorks consultant. They would then come to, say, CHFT to Halifax. Who would be, and they'd be under another consultant as an inpatient, but who would actually have ultimate responsibility for their care? Because I can see sort of a little scenario of too many cooks spoiling the broth, and sort of what was, say, one consultant would think was the gold standard care package, somebody else might, and things could get changed without much consultation between the two people.
I think, and Councillor Reddy was also on the panel, but I think my understanding is that the inpatient service, you would still be under the oncologist that you were receiving the local services from when you were within the inpatient service. And I think that's how they've been splitting it. There was an inpatient service at Pinderfields previously, but because of changes at Pinderfields, I think they didn't have enough workforce to support it. It moved to Leeds during the sort of the 2020, 2021 sort of area. But they've been looking at this, and this is where they're wanting to split their inpatient for non-surgical oncology. I must stress it is for that area. And they've also had a Professor Richards looking at the clinical viability of their options. And the West Yorkshire JOSC have asked to see that report from Professor Richards as well. Okay. Councillor Addy, do you want to add anything that I may have missed?
I don't think so. Basically, it's primarily to enable people to have chemotherapy which closer to home. And the idea is that there's more call for that on the basis if you're going to be an inpatient, whereas the chemotherapy is regular and repeated and you need to be able to get to it, you need support getting there and back. So I think the idea is just to make that a little bit more feasible for people as the intention, but obviously the consultation might suggest otherwise or not.
If I can just come back, is I have no problems with localised care for patients undergoing chemotherapy. What we also have to remember is they build up relationships with their doctors. So we've got the patient from Wakefield who's is under Mr. B. They know the staff there and everything. They suddenly become ill, maybe side effects from the chemo. They then have to go to a totally different hospital under the care, because somebody will be their named doctor whilst they're in that inpatient, and that is my problem with this as well. Is I just feel from a patient's point of view, it's not about, is when you're just having chemo for something, it can actually be quite sort of distressing thing. Just because they haven't had an operation, it is still medical intervention. It could well be that these patients they've had their surgery, they've been discharged from the surgeons, they're now going for their medical treatment.
I agree totally with what's just been said, and I've got personal experience of this both from a recent child and also myself, but I think it's really important about the communication, and it really worries me that it's not going to be joined up, and it feels like for disaster at the moment, because I think, you know, from experience, communication is challenging within the NHS itself, and I can just see a situation where there's a dialogue between, well, he's under the care, this patient's under the care of another department, so he can't make a decision. There's going to be delay. People may end up unnecessarily in hospital. So I personally, I'd like to more assurance around how it's going to actually work. And, you know, even from a systems perspective, do the two hospital systems talk to each other in terms of the NHS records? And, you know, that's already fraught. We know that Harrogate doesn't talk to Pinderfields, Leeds doesn't talk to Kirklees. So how is it going to work? What are the I think more information is required, certainly.
I think you definitely need more information. I mean, my understanding is that the teams will work across the area, and so there will be teams for the Calderdale, Kirklees and Wakefield side, and you will still have your care. If you're inpatient, you will still have your care from that team. But I think you need more information as to the impact from all the questions, more information as to the impact for Kirklees, so that we're not sort of preempting that information and have questions that you need to ask, also about the engagement. Okay.
Also, the question around if people, for instance, in South Kirklees who choose to have their treatment from Barnsley Hospital or at Barnsley Hospital, would that decision mean that they couldn't then go there for any non-surgical? So that's kind of because which also begs the question in the consultation. I'm not sure, I don't know how the consultation was done, and obviously it'd be interesting to find out how that was done and who they accessed for it, because if it was only in North Kirklees and seemingly then available to only people in North Kirklees, they wouldn't capture necessarily people who are currently having treatment elsewhere, because they've made that option to do that because it's actually closer than the alternative in Huddersfield or Halifax.
So I think is the proposal that this panel has, the more detailed item for non-surgical oncology, taking in the questions that have been posed and picking up on the Barnsley aspect as well, and on the engagement that was carried out within Kirklees, so that the panel can have more information locally. Yes?
Yes, thank you, Councillor Smedge. I think there are actually issues about consultation more generally. It's never really clear to me, whether it's Kirklees Council or whether it's NHS or whoever, whether a consultation is about informing people of what they're going to do, or asking people what the people might like them to do, or asking about the reception of certain ideas. And it's never been very clear, so don't think we can do much about that, but it is a problem with the word consultation.
So then, with your permission, we'll add that and ask officers from the NHS to come and speak to you about the non-surgical oncology and the points that you've raised today. The proposal would be, therefore, obviously, because there is a bit of a time frame on this, which is why we are putting it in the February meeting, if you agree, as opposed to the April, because I think in terms of what they're doing, April would be too late for them. So it does mean that we will need to squeeze that onto the February meeting. So the proposal would be to take the Adult Social Care CQC assessment and then ask the Safeguarding Adults Board to try and just keep their comments to the minimum. So if you can obviously we'll probably just go straight into questions in terms of that board report, if that's okay, and then look at the non-surgical oncology for that meeting, if you all agree, and we'll formulate a brief to them based on your concerns you've mentioned today. And then for April's meeting, we're sort of proposing, if you're agreeable, to go and have a visit, if it's possible, to try and arrange it for the time we already have in the diaries for that, for a visit to Knoll House, which is the new dementia daycare facility that will be opened shortly after, I think. So we'll try and fit it in, if it works well with how that work is going on there, we'll try and fit it into the date that you've already got in your diary for a visit out to that. So that's the proposal as it currently stands. Obviously, as you know, with health social care, and it's a bit of a moving feast, so it might well be nearer the time that we might need to put another item in there and rearrange the visit, but we'll keep you updated as much as possible.
Right, so, panel, are you happy with those proposals, ideas? That's the way we want to go forward, isn't it? We're all happy with that. Yeah. Okay, yes, that's fine. Well, we've got to the end of the agenda. Well done. Everybody's had a word, loads and loads of interesting questions, and we've sent some of our colleagues away with headaches, I think, but they need to get it sorted with dentistry in particular, the massive problems. Yeah. Yeah, it's I certainly wouldn't wish to be critical, but we don't always get perfectly clear answers to the questions we ask, do we? I'm afraid that seems to be the way it is at the moment. We'll be wanting clear answers about the inequality, unequal provision of dental care between North and South Kirklees, because I think there could be serious issues there. We don't know until we get the data for it. I think that's it then. Thank you very much, and thank you very much for attending. Thank you.